Senator Hassan.
Well, thank you, Mr. Chairman. And I want to thank Ranking Member Blumenthal, too, for this hearing. And to our witnesses, thank you for being here and for your service to our country's veterans. Mr. Topping, as the VA looks to draft and commence its next generation of community care contracts, it's really important that veterans remain the focus of this effort, and that's what I think you're hearing from all members of this committee today. One particular area I want to make sure that the VA is planning for is the continuity of care. If a veteran is receiving high-quality care from a community provider and the veteran is satisfied with that care, they should be able to keep seeing that provider. So what is the VA doing to ensure that as the next generation of community care contracts come online, veterans can continue to see their preferred current community care doctors without interruption?
Senator, I think the short answer to your question is we have extended the authorization period, and so that when a veteran is referred out, he or she can remain with the provider for the full episode of care. That's number one. Number two, what we've done is we've made it easier through the best medical interest for a veteran and the VA provider to select that that veteran would go to a community provider and remain with that provider for the treatment. So those are the two controls that are in place now too. But what we're also able to do under NextGen, again, our ability to have regional models, and again, what's going to work in Alaska is going to be different than what we're going to do in New Hampshire. Our ability to adapt to the local infrastructure, the local capabilities. So for example, without a full-service VA currently in New Hampshire, we do leverage community care, particularly for the hospital systems that sit around. And Manchester sits in the Boston medical market.
Right.
Unique reach and capabilities. We are able to leverage those in a way that is not going to be one fit. We will be able to adjust to the region to be able to do that. And then as we do work on capacity at the VA in Manchester, we'll be able to do that and respond to that via this vehicle.
Well, I appreciate that, and I appreciate the regional and specific approach. I do also just want to, point out that for some people, the continuity of care is going to be more than, quote, an episode of treatment. They're going to have a condition where they've developed a relationship and a treatment plan with a doctor with a condition that's going to last the rest of their lives. And the notion that because VA changes its contracting relationships, that all of a sudden that person has to transition to a new provider, which does happen in the private insurance market and is a real problem, is something I want you all to think about, because I really want veterans to be able to have that continuity of care. And in a place like New Hampshire, where there are shortages of physicians, it's going to be important that we continue to focus on that issue. Does that make sense?
Senator, it absolutely does, and I'll take that. And again, I think as Secretary Collins implemented best medical interest, this is exactly the type of situation that he sought to address to ensure that there is continuity of care and veterans have the choice to be able to do that.
Okay. Let me ask you another question, because it certainly won't get overlooked in Alaska, but I want to make sure that in all our areas, all our states that have a lot of veterans in rural areas, that we're thinking about access for rural veterans. Where a veteran lives shouldn't determine whether they can get the care and support that they've earned. And because rural veterans aren't always able to easily reach a VA facility, they often rely on community care, particularly, in a mountainous, wintry place like New Hampshire. It may only be 10 miles away, but it might as well be 100 miles away some days. How is the VA planning to address care for rural veterans in these updated VA contracts, and what mechanisms will you put in place to ensure that the recipients of these contracts are providing a robust network of provider options for rural veterans?
Senator, thanks for the question. And 10 miles in the White Mountains could feel like 100, that's for sure. And so part of what we're doing this, and so even for rural veterans, there is a community provider usually local. And that may not be full service, but certainly there's a community provider near, if not in the veterans community, next community over too. One of the pain points on the community care contract has been that it has been difficult for providers to do business with VA. It's been hard to get referrals, it's been hard to get authorizations, it's been hard to be reimbursed. And we have unique requirements. What we are doing in this program is trying to make VA, again, the fourth largest payer, but to make our payer program operate like other government programs, including Medicare. So one example, we use the Medicare fee schedule and Medicare DRGs. The codes that we use are Medicare. Every single provider in rural New Hampshire likely provides Medicare, accepts Medicare and provides Medicare treatment. To the extent that we can operate our program so that it operates like that, and for the provider, ease of doing business with VA, that means our veterans can go local. And if that veteran then needs a higher level of care or specialized care, we may move to the VA or we may move to a specialty provider further away. But the idea is any provider that participates in other government programs, Medicare or Medicaid, can participate in VA community care and provide those same services to our veterans.
Well, I appreciate that, and I appreciate that I'm over time, so I'm going to submit a question for the record on making sure that community care providers are getting the veterans' updated medical records back to the VA before the case is closed out. I think you've recently done a look at that issue, and there's a real problem. Cases are getting closed without the community provider getting the records updated back to the VA. I will also just point out for my colleagues that one of the challenges we have in rural New Hampshire right now is because of the Medicaid cuts that came along with the big bill. 2 of my rural health clinics where veterans might be referred for community care have had to close.